and they will accumulate the cell, and will cause the cell die, right? And it will cause the I call the cytotoxic. Okay? So you should know that for type 1 is IgE, right? For the type 2 is IgG or IgM will cause cell lysis. So for the type 1, is they have the cell lysis? No, just function, right? Just the mediators, right? Okay. So now we go to some disease. The first one is transfusion reaction. Okay. So we know that in our body, red blood cell they have the antigen. So we using the antigen we can identify the different type of the phenotype of blood, right? A, B, and O. Right? For the A they have A antigen, B they have B antigen. For AB they have two type of antigen. Right? For the O, no, is antigen. Right? That you should know that for the A individuals, they have the anti-A, and for the B they have anti-A, and for the AB they have no antibody. For the O they have anti-A, anti-B. Is there any question? No question. So you know that for A person, for the individual, we have the A phenotype, they have the antibody anti-B. Is it clear? Yes? So you know that for the antibody, they need antigen to produce the antibody, right? So for the individual, they have the phenotype A. Why they have not anti-A? They just have the anti-B. Yeah, if they have anti-A, they will bind to the A blood cell, will cause the cell lysis, right? So they cannot have anti-A. Is it correct, right? But for the individual, they have the A phenotype. Why they have anti-B? Anti-B means they have the antigen, no antibody. So where is the antigen? For the person, for the individual, they have this type A, right? So they have no anti-A. Is it clear, right? Yeah. But why they have anti-B? Anti-B means they have B antigen. No antigen, no antibody. Yeah, but my question is why they have anti-B? Where the B antigen? Eat something, right? Anti-B. Yeah. So I have mentioned that for the individual, the phenotype is A, right? They have A antigen, so they cannot produce anti-A. The reason is because most lymphocytes maybe recognize an A antigen, but all these cells are dying, so they cannot produce anti-A, right? But they can produce anti-B, so means that they have the B antigen in the body. They can recognize, right? So where is the B antigen? Yeah, so you should keep in mind that these antibodies belong to IgM. So in the baby, when the individual they are baby, they have A antigen and B antigen. But if they have the red blood cell is AA, the anti-A B cell or T cell will die, right? When the baby in the mother, right? The mother pregnant. But just I have mentioned, but they still have the B antigen to stimulate B cell to produce anti-B. But this antigen is not just limited in the red blood cell. Is it clear? Okay. So you should know that this antigen we using the antigen to type in the human blood cell for the fusion, right? So because they have the anti-B antibody, so this individual they just as a recipient, they just receive the red blood cell is what A, right? If they receive what B red blood cell, they will bind to the red blood cell. They will cause their cell die. That's it. That is very, very dangerous. Okay? So you should know that for as a doctor, you should confirm the antigen. You should confirm the right phenotype before the transfusion. Right? I think no picture. Okay, so this reaction is very dangerous. Why? Because if they have anti-B antibody in the individual, they bind to the B blood cell and they will activate the complement system. You have learned before. For the complement activation, they have three pathways. How many three pathways? Classical, lactin, and alternative, right? So for the transfusion reaction is mediated by which one? Which pattern? Which pathway? Yeah, classical. Classical means that need antibody antigen bonding together. Okay, so we know that they have antibody in the serum. So if we transfuse B typing blood cell, they will bind to the blood cell directly, right? And they will activate the complement very quick and cause the cell lysis. It's very dangerous. Okay? All right. Another type of antigen on the red blood cell, Rh antigen. So Rh antigen just very dangerous for the baby. Okay? So here is some condition for the Rh incompatibility. So the first thing is that the mother is Rh positive, the mother is Rh negative, and the baby, the fetus is Rh positive. So that means they are different from the mother, right? So when during the first pregnancy, the red blood cell, Rh positive are separated from placental, and during the delivery, and this Rh positive red blood cell enter the mother circulation, and for the mother is a foreign antigen, right? And so the mother will activate to the antigen, will produce what? Antibody. And this type of antibody is IgG, it's not IgM. It's IgG. Why this need antigen? We can see this picture show here. And the first pregnancy, right? Mother is negative, and then the baby is positive. And during the delivery, the baby, the red blood cell will enter the mother circulation, and the mother will recognize them and produce IgM, right? IgM. And this the plasma cell, the maybe have the memory B cell, right? And for the second time, the baby is positive again. If the baby is negative, no danger. Right? The baby is positive, so the memory B cell, they will recognize the antigen, right? And this time they will produce what? IgG, not IgM. First time is IgM, right? Second time is IgG. And the second time they produce IgG. We know that IgG, they can go through placental and enter the baby. If they produce IgM, it's no danger because IgM is the bigger one, right? So IgM cannot go through placental, right? Only the IgG can go through the placental, and they enter the blood of the baby. So the baby will cause the red blood cell lysis. So it's dangerous for the second time. Okay? Okay, so for this disease, there are some conditions. The first, the mother is negative. Right? If the mother is positive, no danger. Right? Mother is negative, then the first baby is positive. The second baby is positive again. Is it clear? And the mediator is what? IgG. Only produce IgG. So how to block this reaction? How to treatment for the I think key player is the memory B cell, right? If they have no memory B cell, no response, right? So the best way to stop it is we can use the anti-antibody to block the antigen. If they have no low-level antigen, they cannot release, they cannot form the B cell activate, form the memory B cell. So if we can stop here, we can neutralize the red blood cell within the anti-Rh antibody. See? So for the mother, if they are negative, the baby are positive, for the doctor, what can he do is using the antibody to inject the mother just 3 days after the baby born, okay, to stop the antigen bind to the receptor, to bind to the B cell, okay? Yeah. Okay, so other disease we will tell you later in the next week, yeah. Is other disease, autoimmune hemolytic anemia, Hashimoto, and other graft disease. Okay, so this disease is an autoimmune disease. Okay, so we have learned the RBC transfusion. We have learned RH integrity, right? This is also cause the red blood cell lysis, but the mechanisms are different. Okay, so this disease we know that we're just using some antibiotics, and this biotic can absorb on the red blood cell. So this is normal cell, right? But if they bind to the drug, bind to the medicine, just like this red blood cell are be decorated, right? So if they are decorated, our immune system will consider them as a foreign, as a normal cells, right? So they will induce the antibody, and this antibody bind to the antigen. They will activate the complement system and will cause the red blood cell lysis, just like this picture show here, right? So in some patients, they are healthy before, but if they take some medicine, this medicine bind to the red blood cell, and they will cause the red blood cell lysis, and then we call it anemia. Okay? So these three diseases are different, right? Transfusion, because we're using the long typing of the red blood cell, right? RH incompatibility, because the mother is negative and the baby is positive of RH antigen, right? This one is different. This one is because we're using some drug. We take some medicine, and this medicine really degrades the red blood cell, and our immune system will recognize a foreign one. Okay? Okay? So other disease, just like here, Hashimoto thyroiditis. Do you know this disease? It's happening. No? Doesn't know? Yeah, we know that we have thyroid, right? It's very important for the hormone release. Right? And for this disease, and these are two types of disease. One is graft disease, another is Hashimoto thyroiditis. For the graft disease, they will have the antibody. This antibody is targeted to the TSH receptor. For the Hashimoto thyroiditis, they will anti the thyroid T cell. So this is cell-mediated, this is human-mediated. And consequently, the thyroid cannot work well. So the patient, they have some clinical effect. So we go to this graft disease. You should know that they have this is that's the loop in healthy individuals. We know that. So here is a TSH, means thyroid stimulating hormone. This hormone, this is thyroid stimulating hormone. This hormone is released by the pituitary gland. And if they release the TSH will bind to the receptor. Okay? And this receptor will stimulate the thyroid cell to release T3 or T4 and regulate the thyroid hormone. Is very normal level of the thyroid hormone is very important for our body, right? And if they have the release the thyroid hormone, and this hormone will feedback to this gland. So here this is a loop. This is loop. This is controlled by our body, right? But for the patient, they have the graft disease. We can see here they have antibody, and this antibody just bind to the receptor, and so the antibody mimic the TSH. So they will induce the thyroid cell to produce high level of the hormone, thyroid hormone, right? So high level of thyroid hormone will tell what feedback to the pituitary gland. So tell that we have a high level of thyroid hormone to tell the pituitary gland to release low level of TSH. Right? So low level TSH means they have no enough TSH to bind to the receptor, but they have antibody. Right? So they have a high level antibody. This antibody can mimic the TSH. So for the patient with the graft disease, they will cause this patient, you can see this picture here. The patient are very excited. Why? Because the high level of the thyroid hormone, right? Why level? Because autoantibody, they mimic the TSH receptor. They also telling the pituitary gland to release low level of the TSH, and antibody have more chance to induce the hormone, to induce thyroid cell to release. Okay, so the key the reason is that thyroid stimulator hormone is low level in the patient with the blood disease, but they have high level of autoantibody. Okay, autoantibody. So unlike TSH, these autoantibodies are not regulate. They are consequently they just overstimulate thyroid cell to release the hormone. And so these autoantibodies are also called long-activating thyroid stimulating antibody. Is it clear? Yeah. So this is one good example for the antibody. They have the stimulating function. Okay, stimulating function. Alright, another disease. This also auto antibody, but this antibody is not stimulated. This antibody is blocking antibody. Okay, for this is myasthenia gravis. So they have an antibody. This antibody is bound to what receptor? This receptor is the cellular choline receptor. So we know that for the normal individual, this receptor is very important to recognize the ligand, and this receptor released by the nervous, right? So for the patient, if they have the antibody, this is a block antibody, so this antibody can bind to the receptor. No problem. Okay. So this one. Okay. So this antibody bind to the receptor and block the receptor. So the receptor have no chance to bind to the ligand. Okay. So for the patient, you can see here, the result is a progressive weakening of the scapulated mucus. So this antibody also can destroy the receptor. And so the disease, they will have just like these children, dropping eyelid. They cannot open the eye because they cannot work there of the receptor. Yeah? So this is, I think, is a good example for the autoantibody. His function is not stimulating. This function is blocking. Stop. Okay. So they will reaction the corner of the mouth. Okay. All right. Okay, we finish type 2. Type 2 is still like this. Okay. Now we go to type 3. Type 3. So you have, I'll tell you, type 3, we also call it what? Immune complex, right? So for type 3 is immune complex, they have antibody, right? So this antibody they also is a IgG or IgM. And some disease, just like celiac sickness. Do you know this disease? Yeah, SLEI, right? Maybe you are not familiar with the ulcerous reaction or celiac sickness, right? Okay, so for the mechanism for the type 3, they maybe have the immune complex, right? Here you should know that we have the antibody in our body, right? Antibody combined to the antigen, right? And form the complex, immune complex. So you know that, so we have antibody in our body every day. Why they have no type 3 hypersensitivity? Yeah, so we have the immune complex in our body, in the blood, right? But all the immune complex will be clear in the liver or in the spleen by the macrophage. So they have no disease, right? But if they have a large quantity of the soluble antigen antibody complex, that means they have high level of immune complex, right? High level immune complex will form in the blood. They cannot get removed by the macrophage in the spleen, in the liver. So these complex were lodging in the capillary between the endothelial cells and the basement of membrane. Just like here, this picture show here, this is the basement, right? And this is endothelial. If they have a high level of immune complex, this complex will lodging in the basement. And if they lodging in the basement, they will activate complement, right? And this complement, they will form the complement activation. And this protein, they will attract what? Attract a neutrophil to arrive here because they have the foreign complex, right? So they will attract the neutrophil. So we know that neutrophil arrive here, they will engulf the complex, right? Complex. And after they engulf the complex, they will die, and they will release enzyme. And this enzyme will cause tissue damage. And also they will cause the tissue death, will cause hemorrhage. Right? So you can see this picture here. For the normal vessel blood, they may be a fecal blood. But if they have a new complex lodging in the vessel, they will cause the neutrophil right here will damage the vessel. Okay, so this is the mechanism. And just like this flash show here, endothelial cell, basement, and soluble antigen antibody complex, lodging basement, and activate complement, and they release the attract to the neutrophil. Neutrophil right here engulf the complex, release the enzyme, and this enzyme will cause deep tissue damage. Okay. So now we go to some disease. One is called Usher's reaction. Why we call it Usher's? Because this reaction was formed by the Ushers, by the scientist Ushers. Since this is a skin reaction. So this skin reaction, they just using animal serum to reject the rabbit. And the Ushers found they have the form eczema on the skin. So we now know that many things inject to the dermis, they will produce. If this antigen are foreign antigen, our body will recognize the antigen and it will produce the antibody. And the antibody bind to the antigen, they form the immune complex right, in the dermis. And this immune complex will recall neutrophil. So they maybe cause the blood vessel substitution, they will cause the phagocytosis, they will cause the skin damage. Right? So this, because this is a local inflammatory response, so we call this is a reaction, it's an Usher's reaction. Okay. So in the clinical, we know that for the patient with the type 1 diabetes, they need using the insulin, right? If they using as a doctor, if you find the patient the skin, they have something reaction, you should know that maybe this is Usher's reaction because insulin injection, maybe they have some protein that our immune system will consider as a foreign antigen in the skin. Okay. So other disease is autoimmune disease, just like SLE and rheumatoid arthritis, and some are drug reaction. I have mentioned the penicillin, and some are infection disease, just like this. And these are also from circulating immune complex. So for the type 3, you should know that most diseases are caused by the immune complex. Right? And now we go to two diseases. One is called systemic lupus erythematosus, and this is called SLE. It's happened in the female, most high level in the high ratio in the female, right? So SLE is caused by the fever, weakness, arthritis, skin rash, and all these are caused by the tissue damage. And this tissue damage is caused by the immune complex. That if the immune complex localized immune complex reaction with the different disease, they will result a different clinical effect, right? Just like this is the skin reaction, and we can detect the autoantibody. The green one is autoantibody, and in the skin. We also can detect the autoantibody in the kidney. Okay, so the patient with the SLE, they have many clinical manifestation. Okay. Another disease is rheumatoid arthritis. For the patient with the rheumatoid arthritis, they maybe have the function, the damage in the joint. In the joint. And in the joint, we know that the individuals, they may react to the Fc fragment IgE. And this fragment, they will consider as the foreign antigen, normal antigen, and will form the IgM, induced IgM antibody. So IgM antibody bind to the Fc fragment of IgE, will form immune complex, and will cause the deposit. They cause deposit in the joint. They will cause the reaction, okay, and will cause the chronic inflammatory of the joint. Okay, so this is another disease about type 3. And the type 4 is, we also have another name is called cell-mediated and delayed. Okay, so you should know that why it's delayed, why it is cell-mediated. So, because this type hypersensitivity, they are involving reaction by the memory T cell. Because it's called a delayed type hypersensitivity. So this type T cell, we have the name is DTH. And the first contact to sensitize the person. They also need the first time and second time, just similar to type 1, right? And the second time, they will cause the damage of the tissue. So why the reaction are delayed? Because they reaction within the 2 or 7 days. But for the first time, hypersensitivity, we know that they just happened in within 5 or 10 minutes or 1 hour, right? But for the type 4, they need delay. They need long time. So why they are delayed? The delay is due to migration of the macrophage T cell to the site of the foreign antigen. So as a doctor or as a nurse, if they have a skin test for the type 4, they just ask the individual, ask the patient to go back and will come again 2 or 3 days. Why? Because you should explain why. You tell them they need the time for the T cell, for the macrophage to migration here to the tissue. Okay. So example, you know this tuberculosis skin test, yeah, and the contact dermatitis. Okay. So we go to the mechanism. I have mentioned that for the type 4, they are cell-mediated. So what kind of cell? T cell, macrophage. These are the 2 major immune cells involving type 4. Right? So you can see here, this is the antigen engulfed by the macrophage. And the macrophage can stimulate Th cell to release cytokine and different type of cytokine. This is an inflammatory cytokine, right? And this cytokine, when macrophage release this cytokine, can mediate different clinical effects. Okay, so you should keep in mind that DTH type 4 hypersensitivity is tissue damage. So you just test the tissue. You can see there are many large influx of the non-specific inflammatory cell, including macrophage and T cell. I think the typical disease is tuberculosis infection. Do you know this? Yes. So for the tuberculosis, they are different from the other bacteria. It's what? Insect, right? Correct. So tuberculosis, they can go into the macrophage. They can engulf by the macrophage. But after they enter the macrophage, they live in the macrophage. They are not killed by the macrophage because they release some enzymes, some medicine, some mediators. They will interfere in macrophage to killing them. So they live in the macrophage, so we cannot killing them. But macrophage can present antigen to T cell. So after T cell activation, they will release interferon gamma. Interferon gamma will help the macrophage to killing the tuberculosis. So you can see just for the patient, they have the infection of the tuberculosis. We can detect many granuloma in the lung, right? So just like this is the granuloma in the lung, just a neural-like mass. So you can detect the immune cells. You can find in the center of the granuloma is the macrophage, and the surrounding is what? T cell. Yeah, the bacteria engulfed by the macrophage. Macrophage you cannot kill in the bacteria, right? So they will work together, and form a multiple nuclear gland cell. Means there are many macrophage work together, but they still cannot kill in the tuberculosis, right? So they record what? T cell. So T cell will arrive here and will release interferon gamma and help the macrophage to killing the bacteria. So after the bacteria die, they will form a hole in the lung, right? So this is what causes the intensive tissue damage. But for the patient, how to diagnose is he affected by the tuberculosis? We do the skin test, right? So this skin test is different from the type 1. So for the type 1 skin test, I have shown you that we can detect the different antigen on the back of the skin, right? And for the tuberculosis infection, we just detect skin in the hand. And for here, you should know that they need long time because they develop a red stripe swollen and form the lesion. They need 2 days or 3 days. Why? Yeah, migration. You inject the protein of the tuberculosis. We call it tuberculin, right? We inject them, and we can see here they need the core. They need to attract the macrophage or T cell right here and cause the tissue damage, right? So it needs 2 or 3 days. And here the skin result, yeah, are macrophage. Most cells are macrophage. Now there's a question for you. So if the skin test is positive, what does it mean? As a doctor, you do the test for the patient, right? So you maybe think that it's a patient maybe infected by the tuberculosis. Positive means it's a patient? No. Why? Yeah. It's positive means maybe they have a response. So it means that they have the reaction to the antigen, right? But not means it's a patient. Because maybe in the children, in his children, they have the rejection with the vaccination, right? It's a positive. But now if the negative, it means there are no disease. Negative response. No? No response. No disease. But we also inject the normal dose. But no response. No response. Negative response means no disease? No. Yeah. So no. The answer is no, right? The reason why is negative response? Means no response, right? Why there's no response? Yeah, I think as a doctor, you should be careful to identify, right? To make a decision. Because most patients, they have the tuberculosis infection, maybe have other disease. Just like the patient, maybe they have the infection of HIV. Right, because the HIV destroyed the CD4 T cell. If they have no CD4 T cell, no response. Another example, just like the patient, if they have a heavy infection of the tuberculosis, the skin test is negative. Why? Yeah, because they are over-response. All the T cells are arrived to the lung to cure the tuberculosis. So the immune response is non-negative. Okay, so you should know. Maybe, so as a doctor, you do the skin test, you should ask the patient many questions about other disease and something about how long you get the symptom, right? So you maybe help you to design why the skin test is negative. Huh? Okay, so positive is not, negative is not. Positive not mean that they are infected by the tuberculosis. Negative not means that they have no response, no infection. Okay. Okay, I think this is another disease, insulin-dependent diabetes, right? For the patient, the problem is the beta cell. The beta cell are killing by the cytotoxic T cell. So no beta cell, no insulin. So we need injection, the insulin. Right? So this is a cell mediator. Right? So for the tuberculosis infection, it's CD4 T cell. For the insulin-dependent diabetes, it's caused by the CD8 T cell. Okay, skin test. Yeah, skin test. Skin test because just like the patch test maybe some patients they have the contact dermatitis. Okay, so this patient maybe is allergic to these things, but these things induced in the type 4, not type 1. For the type 1, they are different from the type 1. You can see this figure shown here. For the type 1 hypersensitivity, this antigen will cause the local or the systemic response, right? But for the type 4, only local response, right? Just a contact. If they contact the source and contact other things, they only have the local contaction, dermatitis. So we call it contacted dermatitis. Okay? I think this is the last slide. So after this class, you should know the 4 types have sensitivity, but the mechanism are different. Is it? Antibody are different. Antibody type are different. Okay. So this lecture, after the lecture, you should know the different mechanism, different components. Okay. Thank you for.
I would love this